on now with the key presentations. But before that, I just want to announce that Dr. Spiros Bargios and I will be moderators of this webinar. And it is with particular pleasure to introduce Spiro, because I know him from years back during his training in general pediatrics at our University First Pediatric Department in Thessaloniki. From those days, he had a special interest in metabolic diseases and pursued this further at the Metabolic Department of Great Ormond Street in the UK, where he did extremely well. Currently, he is a consultant in pediatric metabolic medicine and the clinical lead of the Metabolic Department at Great Ormond Street Hospital. He completed his medical school studies in Thessaloniki, Greece, where he also obtained his medical research methodology and basic research degree, and a PhD focusing on the study of extracellular matrix molecules in patients with mucopolysaccharidosis. He completed his general pediatric training in Greece and then his training in pediatric metabolic medicine at Great Ormond Street Hospital. Dr. Bargios was appointed a consultant at GOSH in 2016. Since then, he has been the principal and sub-investigator in multiple high-intensity clinical trials related to the discovery of innovative treatments for patients with various inborn errors of metabolism. His research continues today in MPSs, POMC disease, gangliosidosis, urea cycle disorders, specifically arginase deficiency and OTC, but also lipid-related disorders. He has published widely scientific papers in peer-reviewed medical journals. Spiro, we are proud of you.
Good morning, Professor Savvopoulou. I'm very glad to be with you. So good morning to everybody. I think that speaking about ammonia, as Olga said, it might seem something very basic, but at the same time, I think that it's very, very important, because by thinking and acting on ammonia, you literally can save the life of a patient. So I think that we need to start, because we're already a little bit delayed, and I'm gonna introduce the first speaker of this session, who is a person well known in our field of pediatric metabolic medicine. So Johannes Hamberle is a pediatrician, neonatologist, and intensive care specialist, and a senior metabolic consultant at the University Children's Hospital in Zurich. He is an adjunct professor of pediatrics at the University of Zurich and the head of the metabolic laboratory at the University Children's Hospital. He's a chairperson of the European Working Group for Guidelines for the Diagnosis and Treatment of Urea Cycle Disorders, and a member of the executive and boards of EIMD and SSIM. His research focuses mainly on inherited defects of ureagenesis and on the development of novel treatment options for urea cycle disorders. So I think that he is the most appropriate person in order to give an introductory lecture about the clinical and biochemical aspects of hyperammonemia. Johannes, very nice to see you and very nice to have you today with us.
I would just like to add that I'm particularly happy that Johannes is with us today, and I might say moved with a wave of nostalgia, taking me years back when collaborating with Johannes was a highlight in my learning experiences and much appreciated. We are still learning, of course. Thank you, Johannes.
Okay, so Kalimera to everyone. Thank you, Persa. Thank you, Olga. Thank you, Spiros, for the introduction. Now try to... Can you see my screen as a full screen?
Yes, we can.
Okay, that's reassuring. Thank you very much. So this is my title, but I think the most important part of the that title is what is written here. It's Think Ammonia. I will come back to that very well chosen phrase several times during my talk, because that's in a nutshell, the message, think ammonia. And if we think ammonia late, it will have drastic consequences for the patients. Now, Parasar has introduced ammonia as a silent predator in our lives, and that's true. Ammonia is everywhere, and this is a picture that was published by NASA some years ago, and it tells you that ammonia is everywhere in the orbit. So you can't escape this very small molecule of a single nitrogen and three or four hydrogens. Ammonia is everywhere. Here it is depicted as an ammonia gas cloud somewhere in the orbit, quite far away. When you talk about ammonia in the human, we speak of either ammonia, which is NH3, or ammonium, NH4, which in fact is 99% of the ammonia in our blood at physiological pH levels. It's a small molecule, so it can easily diffuse from the bloodstream across the blood-brain barrier into the cells of the brain specifically. Here's a publication that colleagues in Japan published some years ago, and they looked into more than 200 patients with urea cycle defects. Urea cycle defects are certainly one group of conditions in which hyperammonemia is an important issue, but it's not the only one, as we will see in just a minute. But here they talk about urea cycle disorders. And they could show that the initial ammonia levels, so that means the first or the second ammonia level that is found in a symptomatic child, mainly children were included here, strongly determines the outcome of the patient. And you see here on the x-axis the ammonia levels, and you see the numbers of patients on the y-axis, and you see that the normal ones, so these are the white ones, they are only found in patients with an ammonia level that does not exceed 300, 400 micromoles per liter. If the initial ammonia is beyond that threshold, 300 to 400, in the paper they depicted 360 as their cutoff. If the ammonia level, the initial ammonia level exceeds that threshold, the prognosis is quite bleak. So you see that the vast majority of those patients with ammonia levels higher than 500, higher than 360 in that region, they are either mentally handicapped or they died. And that is why the phrase "think ammonia" becomes so important. If we think ammonia too late, patients have a higher risk of being in that category and having higher ammonia levels and having a poor prognosis. So I think the purpose of this webinar is to make us all aware that only if we think ammonia early in the course of a patient, the patient can still have a good prognosis. Very often, unfortunately, we see the drastic consequences on the brain in severe hyperammonemia. Here is the case of a 16-year-old girl, and she got some medical treatment, in this case with valproate, and developed somnolence and later fell into coma. When she did so, a CT scan was obtained. And this is the initial CT scan in that patient, already comatose, but having a normal brain CT. 2 days later, she had a severe brain edema, and she never recovered from the somnolence and coma, but she died. And that is the effect of the high ammonia in that patient. And it's only within 24 to 48 hours that very severe and irreversible brain edema can develop. Another patient, in this case from literature, a patient with neonatal onset citrullinemia. Also, this patient had a very severe brain edema. And here you see the consequences of the brain edema after just over a month. There are cysts formed in the brain in most places, and here at autopsy, because also this patient died, you see the huge destruction of brain tissue as a consequence of brain edema. So these were two cases, one as an adolescent and one as a neonate. There are many cases, and we will hear later from Elaine Murphy and others about such cases. I only want to illustrate how difficult it can be to detect those patients. I only want to illustrate that and add one further example from literature. Here's a 19-year-old female. She was found unconscious, nausea and vomiting in the preceding weeks. She was declared brain dead without a definite diagnosis. So her liver was transplanted into someone requiring liver transplantation. The recipient of that liver soon developed hyperammonemia, brain edema, and death. And only then the diagnosis of OTC deficiency was made. Here are MRI scans of the recipient where you see the drastic consequences of that situation in the patient. And you see that you can get 19 years old without a diagnosis of OTC deficiency, and you can suddenly die, and you may not be diagnosed because everything is so unclear. That's one extreme example, but that's by far not the only one, published 7 years ago by colleagues from radiology. A little bit about biochemistry. Here we have on the very left side a single liver cell, and that is in the periportal area, an hepatocyte, a liver cell. And we see here a mitochondrium depicted because the urea cycle, which is the main pathway of ammonia removal, I mean, that's really the main pathway of getting rid of ammonia, is located in the mitochondrium as well as in the cytosol. This pathway, the urea cycle, has 5 or 6 enzymes, depending on how you count, and 2 of them, CPS1 and OTC, are mitochondrial. 3 are cytosolic, ASS, ASL, and arginase. And there is NAGAS, that's an enzyme that produces an allosteric activator of CPS1, which also is mitochondrial. And as it is present in 2 compartments, mitochondrion and cytosol, there's the requirement for a transporter, which is the ORNT1 transporter that shuffles the metabolites of the urea cycle from the cytosol into the mitochondrium and out again into the cytosol. There's also another transporter required, citrine, which is again a mitochondrial transporter at the inner mitochondrial membrane. This transporter transports aspartate from the mitochondrium into the cytosol, which is one of the substrates of ASS, arginine succinate synthetase. So this is the urea cycle. And this cycle can, of course, be affected by a genetic defect of any of the enzymes or the transporters, CPS1, ORNT1, etc., etc. And if so, if there's a defect, a genetic defect in any of these enzymes or transporters, we use the term primary hyperammonemia, and that describes a defect within the urea cycle, a genetic defect within the urea cycle. It can be quite variable, it can be quite mild, it can even be asymptomatic, but it can also be very drastic. In addition to primary hyperammonemia, and that's quite important now, there's secondary hyperammonemia. And secondary hyperammonemia describes a condition in which the urea cycle itself is working perfectly. All the enzymes, transporters, everything in place, everything working, but there is a defect outside the urea cycle with a consequence on the urea cycle. And while in the first case of primary hyperammonemia, there are 8 different conditions possible, the enzymes and transporters. In the case of secondary hyperammonemia, there's a long list of differential diagnoses, organic acidemias, fatty acid oxidation defects, mitochondrial conditions, drugs, chronic liver disease, etc., etc. A long list of differential diagnoses that can lead to secondary hyperammonemia. Now, if you are faced with a patient in whom you find hyperammonemia, it is not obvious from the level of ammonia whether you have a patient with a primary hyperammonemia or secondary hyperammonemia. Patients with organic acidurias, for instance, they run exactly the same levels when they manifest as do patients with a primary urea cycle defect. So we need more tests to distinguish the two groups. And it's important, it's not just academic, it's not just for research, it's important for the patient that we understand whether it's a primary hyperammonemia with defect within the urea cycle or something outside, because it will have consequences on our management of the patient. I briefly talk here about the situation in organic acidemias, and the reason for doing this is because they are of likewise importance than the primary hyperammonemias. If you look at numbers of patients, and you will see in your practice, in your hospital, being a neonatologist or being a general pediatrician, you will see about the same numbers of urea cycle defects as organic acidurias. At least in most of European centers, this will be the case. And as I said before, the etiology and the biochemistry behind hyperammonemia is different in organic acidemias, and I briefly want to talk about that. We have a little bit of more complex figure here with urea cycle, and we have adjacent pathways, such as, for instance, the TCA cycle, and we have here the degradation of branched-chain amino acids. And we see with those blue boxes primary enzymatic blocks that lead to organic acidemias. So for instance, here in the degradation of leucine, we have a blue box indicating isovaleric aciduria caused by a defect in IVD. We have here further downstream of the branched chain degradation pathway, another blue box indicating the location of the condition called propionic acidemia. We have here up in this area an X. An X indicates secondary enzyme inhibition. And in many of the conditions that lead to organic acidemia, we have a secondary inhibition of this enzyme that I mentioned before, NAGAS, N-acetylglutamate synthase, which produces the activator of CPS1 of the urea cycle. And you see that several metabolites that may accumulate in any of the organic acidurias inhibit NAGAS. Other metabolites also produced by organic acidurias inhibit the step from pyruvate into the TCA cycle, or this step again inhibited by other metabolites produced in organic acidurias. And you find here many of the X's because we know now that several of the metabolites of branched chain amino acid degradation can impact on the TCA cycle. So we have a multitude of metabolic blocks that are secondary and that are caused by the metabolites that accumulate in organic acidurias and that in an indirect way impact on the urea cycle, mainly through the action of NAGAS inhibition. I come now briefly to the clinical symptoms, and very unfortunately, the symptoms of hyperammonemia in neonates are entirely unspecific, and this is why we need to include ammonia in our early thinking when we are dealing with a very sick neonate. It's not just bacterial sepsis. Bacterial sepsis is, of course, far more common in a neonate, an ill neonate on day 2 or 3, early onset sepsis, but it's not always bacterial sepsis. Patients usually manifest with feeding difficulty, vomiting, somnolence, coma. They may have muscular hypotonia. They may have seizures, but that's all unspecific. Typical for a metabolic disease would be a very rapid deterioration from day 2 of life after a perfectly normal day 1. And a very common initial diagnosis and misdiagnosis in these patients is bacterial sepsis. And we are losing a lot of time by first treating the patient with antibiotics, waiting for the success of that, and only on day 3 or 4 think of other possibilities. And since the brain is affected so drastically by ammonia and at risk of getting severe and irreversible brain damage, I think this audience should include ammonia determination earlier in the course of management in those patients. So when I say include ammonia, I of course mean the determination of plasma ammonia. And the guideline group that I was part of, we considered a plasma ammonia determination in every unexplained encephalopathy. So we found it justified in a patient with an unexplained encephalopathy, which is, of course, a matter of definition. But if you find a patient that has a new neurological situation with somnolence, with subtle neurological signs, or with even drastic coma situation, if it's unexplained, consider including ammonia early in your diagnostic workup. Also, suspected intoxications. There are many examples of patients who, in a situation with unexplained encephalopathy, were screened for intoxication and were found in the end to suffer from a metabolic disease. And in fact, there are some eminences around that had more metabolic patients in the group of patients with suspected intoxication than confirmed intoxications. And also, we should include ammonia determination in our considerations of every neonatal sepsis. I'm not saying we should measure ammonia in every neonatal sepsis. If there's a clear indication for a bacterial sepsis with a respective history in the mother and during birth, then there is probably no need to determine ammonia. But if it's unclear, if there have been no ruptures of membranes, and if the mother has not a respective bacterial colonization, then we should think of ammonia determination. There's some practical aspects that I would like to mention, because very often in clinical practice we have slightly elevated ammonia and then it's unclear, is it true or false? Try to collect free-flowing blood. Always transport the blood sample in ice water. And we heard before that it appears to be practice in some Greek hospitals to transport an ammonia sample to another hospital. If that is the case, make sure the sample is in ice water. It should not be on ice, because then the sample may freeze, resulting in hemolysis and false high ammonia levels. So always transport the sample in ice water to cool it down, but not to freeze it. And in any case, try to perform a fast analysis, and certainly such a sample cannot wait until over the weekend. To determine ammonia, you have two principal technical ways. The most widely used way would be a spectrophotometric assay, which is a direct assay that can precisely quantify ammonia. But in the absence of such a machine, you may be using a handheld device that is easy to use. It's not as easy as a glucose device, but it's almost as easy. And this can be used at least to exclude ammonia, because if you have a result that is in the low range, then there's no need to think of ammonia. Those handheld devices have certain disadvantages. They only can measure up to 300 micromoles per liter, and higher levels are not detected, but they can be used for excluding hyperammonemia. Just one practical word, this machine down here is available in most laboratories because it's exactly the same machine that also measures, for instance, transaminases or creatinine. And this is often done in a lab. So it's not a matter of the equipment, it's more a matter of the kit. And you may want to talk to your laboratory, asking them to buy the respective ammonia kit to run the sample on the same machines, if that is not yet practice in your lab. If we are considering patients outside the neonatal period, and we will hear later from Elaine Murphy about that patient group more, but only to say very briefly, it gets even more confusing because the symptoms of patients with hyperammonemia can be variable. It can be neurologic, can be as simple as headaches, migraine-like, can be learning disabilities, can be psychiatric symptoms. It can also be gastrointestinal, abdominal pain, hepatomegaly, protein aversion, and it can be often episodic, for instance, during the bleeding cycle in women, or it can be just an affection of the hair, fragile hair, which is typical for one of the urea cycle defects. If you're now considering what to do next after ammonia has been found elevated, there is a few tests only, and that's an important message, few tests only that you need to do to confirm the presence of a primary or secondary hyperammonemia. I think in most patients or in all patients, you will do some additional bedside tests that include blood gases, glucose, lactate, and apart from that, you will only need electrolytes, creatine, transaminases, and maybe coagulation parameters. And then really from a metabolic point of view, you need a couple of tests to measure the profiles of amino acids, of organic acids, this is in urine, of purines and pyrimidines, or just one of the metabolites of the pyrimidine biosynthesis pathway, orotic acid, and you may want to measure the profile of the acylcarnitines. And with those tests, basically with those 3 to 4 tests, you can distinguish the majority of the primary and or secondary hyperammonemias. We had an algorithm published in the revised urea cycle disorder guidelines that includes the differential diagnosis. It's not 100% of the differential diagnosis. There's a few that are not part of it, but it's the vast majority. So you would first want to look at the glutamine levels. Second, you look into the citrulline levels, and then you work your way down to a specific differential diagnosis if you find some abnormalities. This algorithm, I don't want to talk longer about, but yeah, you may want to read that and have that present in your practice because it helps to distinguish the different diseases. For confirmation then, if you arrive at a suspected diagnosis, nowadays it is mainly mutation analysis. In the past, also enzymatic or functional tests were done, but this is now mainly replaced by mutation analysis. It's available in many centers. It can be done, of course, from many different matrices, blood cells, dried blood spots, fibroblasts. Now, widely available is next-generation sequencing. It has several limitations, but also it has, of course, advantages because you get the full picture in just one shot. I would want to highlight that using RNA sequencing will increase the sensitivity of your genetic testing. I know it very well from own practice that there's probably about 10 to 20% of the patients that will not arrive at a diagnosis only based on DNA sequencing, even if it's done with powerful machines such as next-generation sequencing, whole exome sequencing, whole genomic sequencing, etc. You will need complementary to that RNA sequencing, and you should also include the regulatory elements of genes into your analysis. The standard methods slightly depending on what is available in different laboratories. Standard methods only detect 80 to 90% of genotypes. So that's quite a considerable number of patients for which you will need to look into, as said, regulatory elements, introns, promoters, or perform RNA sequencing. That's just a brief comment. Now I'm moving away from clinics and diagnostics and talk a little bit about the management. And very general, a majority of patients with symptomatic hyperammonemia, irrespective of the cause, whether urea cycle defect, organic acidemia, or any other cause, will need a restriction in their natural protein intake. And very often that is done to an extent that you will need to supplement essential amino acids. Many patients with chronic hyperammonemia will need medication, and so far the mainstay of medication to fight chronically increased ammonia levels is the use of nitrogen scavengers. I would like to highlight that it's indeed a nitrogen scavenger, not an ammonia scavenger, because the substances that are here in discussion are benzoate or phenyl acetate, and those two metabolites, they do not bind to ammonia, but they bind to amino acids, in the case of benzoate to glycine, in the case of phenyl acetate to glutamine. So they capture nitrogenous amino acids and metabolize them into non-toxic metabolites that can be excreted in urine. So nitrogen scavengers is something that many patients will require, and some patients may benefit from the use of metabolites from within the urea cycle, because then the urea cycle can run faster, but that's limited to some of the patients. And then, unfortunately, patients may require a liver transplantation, which is so far the only cure. I'm strongly hoping and believing that there will be some important changes in the near future to that, but so far it's the only cure in a patient that has very severe neonatal hyperammonemia and or recurrent severe life-threatening or brain-threatening hyperammonemias. The principles of therapy for hyperammonemia, in any case, and irrespective of the cause, is to get the patient into anabolism. So get the patient out of a protein catabolic situation. And the other principle is, of course, to remove the ammonia, because that is toxic and is toxic within a few hours only. To get a patient into an anabolic state means to provide sufficient energy, and please calculate carefully the amount of glucose or dextrose that you give to the patient. Very often with standard infusions over a peripheral line, you only give below 100% of the energy requirement. At the same time, make sure the patient receives the minimal required protein content, because if the patient gets less than what is required, the body will recognize, will sense that, and protein catabolism will continue. So we should carefully avoid the deficiency of essential amino acids, of trace elements, and of vitamins. In the guidelines, we recommend to stop the protein supply, enteral protein supply, for no longer than 24 to 48 hours. So latest on day 2 to 3 of treatment of a patient with hyperammonemia, you have to reintroduce at least the essential amino acids. A patient that is not anabolic will not get rid of his or her hyperammonemia state. That's the message here. And for ammonia removal, there are a few measures that can be done. Nitrogen scavengers, I mentioned already. I also said amino acids can be used. We have carglumic acid, which is an analog of the product of NAGAS, the enzyme that produces the activator of the urea cycle. That is helpful in several conditions with acute hyperammonemia and very effective, in fact. and then hemodialysis or hemodiafiltration, and I will come to that in just a minute. Briefly on the rationale of drug therapy, nitrogen scavengers, we mentioned already the different compounds, benzoate, the phenylacetate comes as drugs in different forms, either as sodium phenylbutyrate, which is a prodrug, or more recently introduced into the market and with benefit for the patient in terms of palatability and hence hopefully of compliance, glycerol phenylbutyrate. These are medications, well, this is a medication, this is a chemical only, that provide alternative nitrogen excretion for the patient. Amino acids, arginine and or citrulline, would support the residual urea cycle function, but that can only be given to specific patients, and that requires the precise diagnosis. I mentioned already carglumic acid, which can stimulate the first urea cycle enzyme CPS1, a chemical analog, and there are cofactors that mainly cofactors of pathways outside the urea cycle that improve their respective residual enzymatic function. That's mainly the case for organic acidemias. So if we look at that on one slide, management of hyperammonemia would require the start of intravenous glucose or dextrose immediately, with the aim to provide at least 110% of the daily energy demand, and it's irrelevant whether you give that enterally or intravenously, but you should aim at least 110%. You may want to give L-arginine as a bolus infusion in the beginning of acute hyperammonemia. Same with nitrogen scavengers that can also be given intravenously, and you should consider the use of carglumic acid. In any case, what you should do with a patient with symptomatic hyperammonemia is to consider to transfer that patient very early in the course to a specialized center. And that depends on whether you can offer, for instance, hemodialysis. And we will discuss that in just a minute, but that's, I think, something that has a huge impact on the outcome of patients, whether they are transferred early to another center for complete and proper management, or whether they are kept in other places where not the entire treatment options are available. One word to liver transplantation. I said already that's currently the only cure. Certainly it's the first choice and recommended for any patient with a severe neonatal onset hyperammonemic condition. It should be done early, that means before severe brain damage occurs, but still for reasons of safety and reasons of success of the liver transplantation, it may not be best to do it in a neonate immediately, but to wait until the patient has a weight of about 5 kilograms. This number has been the conclusion in the guidelines. And there's support for the recommendation for liver transplantation, again, in a large number of patients from Japan, where they looked into transplanted versus non-transplanted patients. And you can see from the colors only that the group of patients that eventually are diseased or mentally handicapped is larger in the non-transplanted cohort. Now, one word to hemodialysis or extracorporeal detoxification. There has been a Nature Reviews paper, which I still find very comprehensive some years ago, a consensus guideline. Basically, it's recommended to consider extracorporeal detoxification immediately if ammonia exceeds 300 to 500 micromoles per liter, and or if there's no response to drugs within a few hours. I would like to mention now a study that we did, a retrospective study, in which we evaluated the use of dialysis in patients with acute hyperammonemia. And we included in this study about 150 patients, and some of them received dialysis and the other, of course, not. And they were of different urea cycle defects, both proximal and total. Maybe we look only into the total number. About 2/3 of the patients received dialysis and 1/3 did not receive dialysis. Now, the important information that I want to highlight is on that slide. We have here 166 patients depicted by either a circle or a triangle, depending whether they received no dialysis, which gives a circle, or a triangle if patients received a dialysis. And then we have on the y-axis the ammonia levels. We call them trigger ammonia because that was the ammonia level that triggered the decision to go for dialysis or not. And then we have 4 categories. We have normal patients, that's the second column. We have diseased patients, and this is the first column. And then we have some in which we don't have information and patients that are handicapped. And the point I want to make here is that we have in both groups, those that are diseased and those that are normal, we have the same ammonia levels. So take, for instance, a patient in the normal column, and here the circle indicating no dialysis. This patient, this specific one patient, had an initial ammonia level of about 2,500 micromoles per liter, was not dialyzed, but still had a normal outcome. Take in contrast this triangle, patient in the first column. This patient has a triangle, so he or she was dialyzed, but the initial ammonia, or the ammonia that triggered the decision, was below 1,000 micromoles per liter. And this graph shows, I mean, that's retrospective data, so take it with some caution, but still, the information from those patients tell us the way we are currently performing dialysis in this group of patients is not impacting on the outcome of patients, whether they are dead in the end or whether they have a normal outcome. And our conclusion from that observation was that we are performing dialysis too late. It's not that dialysis is inefficient. Dialysis is highly efficient to remove ammonia, but we are starting dialysis too late to get the benefit of the intervention in terms of outcome of patients. And I think that's one, again, important point from this webinar. Ammonia is so drastically toxic to the brain that if we find hyperammonemia in a patient, we need to remove ammonia very fast, and that includes currently dialysis. And this needs to be done earlier than we did in the past. I have one more slide on treatment options that are more preclinical / started into clinics, and I only want to go briefly through that. One word to AAV gene therapy, because that's, in terms of gene addition, gene replacement, the most advanced. What I observe, and that's kind of a conclusion from AAV therapies, there are several issues. Probably one of the most important is the pre-existing antibodies against the AAV. And there's some considerations towards immunogenicity. So only with current vectors, only a single dose can be given. That's unfortunate because there will be loss of efficacy upon cell division, and the liver is a dividing organ, although slowly in adults. And there's a considerations risk of malignancy. Another pipeline is the use of mRNA therapy. And there's a trial currently going on by an American company in which mRNA, OTC mRNA in this case, is formulated in a lipid nanoparticle. If that works, and I think in principle there's a high chance of this method working, nevertheless, that's not a cure, and the efficacy is only given if there's repetitive weekly or bi-weekly infusions of that drug. Another principle or possible option is enzyme replacement, or rather I should say enzyme substitution therapy. And there's now a licensed drug on the market for one of the urea cycle defects, arginase deficiency. The general problem of giving recombinant enzymes is to target either the mitochondria or the cytosol. So therefore, in the case of arginase deficiency, the drug is not targeting the liver cell, but it's working within the blood to reduce the concentration of arginine, and by that reduce the consequences of the deficiency. Very unfortunate, hepatocyte or any other cell-based therapy, stem cell transplantation, hepatocytes of different origins have so far shown insufficient efficacy, often due to an impaired survival of transplanted cells. So that line of treatment, although present for the last 10 or 20 years, has not been as successful so far. I will now use the last few minutes to consider just one thing, and that is liver zonation. I've shown the hepatocyte on a very early slide, and I've mentioned there that's the periportal hepatocytes where the urea cycle is expressed. And that is an important consideration if we talk about the measurement of efficacy of, for instance, gene therapy. Biomarkers may not be sufficiently informative. In the case of gene therapy, it will be difficult to determine the efficacy only by measuring amino acids or ammonia, because very often patients are in a stable metabolic situation anyway. Liver biopsies will also not provide a sufficient result because of this fact that we need to correct the defect in a specific compartment of the liver, specifically the periportal hepatocytes. So one thing that we did in our lab was to consider a functional assay as a solution to this. Very briefly, we have here the urea cycle, and we have glutamine as one of the most nitrogenous amino acids, and we have here the ammonium molecule that enters into the urea cycle, finally being excreted as urea into the urine. And if we now give a label, a tracer, an ammonium molecule that is labeled by a stable isotope, and that is no longer 14N but 15N, we can observe now the traveling of this label through the urea cycle as labeled citrulline, labeled arginine-succinate, so forth, until we can measure labeled urea. So this is a means of studying the flux through the urea cycle in a patient with an impairment of urea cycle function, either primary impairment or secondary impairment. And all that is required is to give a very small amount of tracer, in this case ammonium chloride at a very low concentration, and then measure how this labeled ammonium chloride travels through the urea cycle and arrives as labeled urea. We measure that with a high resolution machine, and that allows to use a very low dose of the tracer. That does not put the patient, even with a severe urea cycle defect, at any risk because the dose is just so low. Here are some results, and we soon publish these results. Publication has already been accepted, so we're currently studying the proofs. And you see in black the line that we observe over 2 hours in control groups as a fast increase of the label that we measure in blood, and that stays over 2 hours. And you see in different colors, different patients with different defects of CPS1 deficiency, OTC deficiency, so forth, up to arginase deficiency. And you see that some patients have a very low level and remain to have a very low level, meaning that there's no flux through the cycle, while others have a slower increase, but then reach a plateau that is similar to the controls. And we think that this functional test allows us to study the flux and the capacity of the urea cycle in more detail than single metabolites would allow. So let me summarize. I highlighted several times that ammonia is highly neurotoxic, can lead to irreversible brain damage. The cause can be very different, can be inherited, can also be acquired. There are different mechanisms of pathophysiology. We did not talk about that in much detail. Management is acute or long-term. It's important to know the underlying disease in detail, which can be achieved by a few metabolic tests. And the prognosis, and this comes back now to think ammonia, really largely depends on early start of treatment. And if we lose time there, and if we think too late of ammonia, it will have drastic consequences on the patients. With that, I end, and I'm happy to take questions. Thank you very much for listening.
Thank you very much, Johannes. That was a great, introduction on ammonia and what we are discussing today. People can ask questions via chat, I think, as well. So let's wait for a couple of minutes. I just wanted to say that there are a lot of things that I think general pediatricians and neonatologists need to keep in their mind when it comes to ammonia, from the things that you said. And I think that an important message is that we should check ammonia in any unwell neonate who is like systemically unwell, because we might miss cases otherwise. The practical aspects that you've mentioned, I mean, we receive a lot of times phone calls about high ammonia levels that have been taken from heel pricks, especially in neonates. And then it's a little bit difficult to give advice about the management without having like a proper sample of ammonia. All the things that you said about the differential diagnosis, for example, it's so important to think that actually the three main group of metabolic disorders that can cause high ammonia, like urea cycle disorders, organic acidemias, and fatty acid oxidation disorders, can be basically, have a very good differential diagnosis just by measuring ammonia, blood gas, and ketones, and then do all the rest of the tests that you've mentioned. And, it was great to see as well some new data about all the clinical trials that are happening at the moment. Just one brief question from me, Johannes. When, based on your practice in Zurich, like when is it too late to treat ammonia? Because we often come in London in front of cases where, the ammonia was so high and the damages that have been done so great that we basically advise withdrawal of care in patients with high ammonia levels. So what would you say in terms of that? When are we too late in treating ammonia?
I think, Spiros, thank you for the question. That's an extremely difficult to answer question, because it's so highly variable, as you probably also have experienced. I remember patients that were running, the highest that I've seen was a patient that had 8,000 micromoles per liter of ammonia in blood, 8,000. And that was confirmed. It's not just an artifact, but that was confirmed. This was a patient with a transient hyperammonemia. At least that was our conclusion, because we did not find a diagnosis. And I was caring for that patient for 5 or 6 years after the neonatal crisis. And I know the patient had some but mild neurological impairment. And I only mention that I think it's extremely difficult, based on the ammonia levels on only 1-2 days, to make a precise prognosis for a patient. So we have to take into account the entire clinical situation. If that patient has, in addition to a very high ammonia level, also signs of brain edema on ultrasound, or the clinical situation with deep coma or seizures, would suggest that ammonia has already a severe impact on the brain, I think that changes the situation. So I think we have to look not just on a single ammonia level, but on the entire situation. For how long has that hyperammonemia already been present in the patient? What is the clinical situation in the patient? And then I fully agree, there are certainly patients in whom also we in Zurich advise to not proceed to further therapy. But that's, in our view, it's an individualized decision, always terribly difficult, and I cannot give any better advice.
I agree with you. It's always very, very difficult to advise on something like that. Professor Savvopoulou, do you have any question, or shall we dismiss Johannes?
I would just like to make a comment. Thank you for your wonderful presentation, Johannes. We have indeed come a long way. New vistas are continually unfolding. your publication in the Journal of Inherited Metabolic Diseases, Quo Vadis, Where Are We Going, with the allied conditions is particularly worrying. I just want to ask you your input. I would like about low levels of ammonia when following the patient, which are not always a reliable index of the hepatic encephalopathy. It appears that there are other factors involved as well. I was fortunate to hear a presentation from the Liver Access Group in London about these cofactors, you know, with the lactate, with the hypoxia, with, to be honest, complicated. But I would like your input on that.
So you are referring to situations in which ammonia is only slightly elevated, but other pathways always are impaired, indicated by elevated lactate or hypoglycemia. Is that what you're referring to?
No, not, well, what I was, okay, other factors, but in the following of a patient who is known to have a urea cycle defect, that the low ammonia levels where the glutamine is still very high, you know what I mean? That ammonia is not a reliable index. We should definitely also do the amino acids. That's what I want to.
Okay, now I got the question. That is true. Ammonia is just one metabolite. The reason why we measure it is because it is easy to measure, if it can be measured, of course. There's a fast way to analyze, while at least in the past, the amino acid profiles have taken much longer. Something that changed, of course, now with the tandem mass spectrometry of analysis of amino acids. If there was the possibility of a bedside glutamine test, this may be more informative than a bedside ammonia test, because glutamine plays, as you rightly say, an at least as important role for the development of brain edema. In fact, many people think that glutamine and the level of glutamine in brain is also determining the extent of brain edema. I think it's just for practical reasons that we are measuring ammonia and not glutamine. One other thing is that very often, we have to be clear that we are measuring the peripheral situation, and that is not the same as in the brain. There's a few comparisons in patients that, the periphery, meaning ammonia and glutamine in blood, comparing ammonia and glutamine in CSF. And very often there's a huge discrepancy with much higher levels of both ammonia and glutamine in CSF than in blood. So I think some patients already have normal levels of ammonia in blood, may still have elevated glutamine levels in blood, but situation in CSF may be totally different, and levels of ammonia and glutamine in CSF may be still much higher.
Thank you. That's very interesting. What's going on in the brain and the CSF. Yeah, thank you, Johan.
And one specific question as well, Johannes, for you, since you've mentioned ureagenesis, there is somebody asking do you think that ureagenesis should be, tests should be performed in donors for liver transplantation before, giving liver for transplantation?
I know the reason to ask this, but I would not go as far as that. Very often there will be no time to, if you have a donor, a classical donor, that will be a brain dead individual, and you probably don't have time to perform this ureagenesis test in that situation, because it needs some preparation. It should be a stable metabolic situation. So I think for practical reasons, it would be extremely difficult to run this test in a donor. If it's a living donor situation, and if there, for instance, is the question about heterozygous parent, then it may help to determine to what extent is that heterozygosity impacting on the urea cycle function. But I wouldn't advise that as in general for all liver donors.
Excellent.
What you mentioned about the liver transplantation difficulties, are liver transplantation centers aware of the fact that they should also beware of urea cycle defects in the donor? Is it, have they been informed of this? Because like you said, there have been deaths from a donor who had, for example, OTC deficiency. So it's very important to the liver transplantation centers to be aware of this.
Absolutely. And I think there is still a lack of information on that possibility. At least you can read it from the constant case reports that come on that topic. So it's not that it was only in the past, like 10, 20 years ago, that these cases were reported, but there's also recent examples of very similar cases. So I think there is a lack of information on that possibility.
Yeah.
Excellent. Thank you very much, Johannes. And I think that we need to move on in the next lecture. And there